just about to get started on the webinar. Dawn, I don't see my PowerPoint on the screen in front of me.
You have to hit. You're going to hit Show My Screen, Dan.
Got it. Yeah, it's not coming up for some reason. It's the Show My Screen button has a pause symbol on it, and I just press it, and it turns into an arrow, which is a play. But I don't see my screen on the air. Can you do you see my screen on the air?
I see. Yeah, I see your screen. I see your background picture right now.
I don't. Okay, so am I showing? Okay.
You just have to pull up your presentation.
Okay, I thought you had it on your. I apologize. Okay, we just do it right now. Okay. Everyone see it? You see it, Dawn?
Yeah, we can see it.
Okay, apologize for that, guys. All right, let me just. I'm going to run it through it as a PDF. It doesn't make a difference. So today we're going to talk about chronic care management, which I think is an extremely important program that CMS has just developed. And what we'll do is I'll go through the presentation, and then at the end of the presentation, we will take some questions. If you could just put your questions in the chat box, that would be great. Move this down so I'm not starting. Okay. So, chronic care management is a program that was begun in January 1st, 2015. Medicare included on its fee schedule payment for the first time for non-face-to-face care coordination. The concept is that patients who have two or more chronic conditions that are expected to last at least 12 months are eligible to be part of this program. The problem sought to be addressed by chronic care management is that when you have patients who have multiple chronic conditions, those conditions can often get worse and can exacerbate between regular visits. Those patients sometimes allow their conditions to develop beyond the point where they can be treated at a physician's office. They often end up in the hospital. They end up needing much more extensive care than they typically would if their condition could be dealt with in a faster and more regular manner. So the concept of chronic care management is to deal with the fact that there's been an extensive amount of research that shows that if patients have regular access to caregivers, they're less likely to to develop acute problems, which ultimately reduces the cost of care and frankly helps patient population as well. This is right now. This program is only open to Medicare, but there's strong indication that it will be opened up to private payers as well once the data from the CCM program comes out and shows that it really does in fact reduce the cost of care. As I mentioned, the CMS implemented this January 1st, and so at this point, any medical practice that has patients with multiple chronic conditions can implement this process. Medicare, the only requirement really that Medicare has in terms of admitting a patient to the program is that they have to have two or more chronic conditions. The service the service provided, so my screen is coming up. The service can be provided by non-physicians, which is really important. And one of the things I want to add is that this presentation is extremely detailed. The written presentation is very detailed. I included pretty much everything that any practitioner would need to know or want to know about CCM. I'm not going to go through every slide in great detail because it would take too long and it would put everyone to sleep. But the slideshow is available to anyone who attends this webinar. So if you want to delve in more deeply into this program, you're certainly welcome to. But I thought, let me provide everything that there is, so that you didn't miss anything. So practitioners can utilize physician extenders in order to implement this program, which is really important because most physicians want to avoid phone calls. It's expensive to have physicians make calls. And as we'll talk about later in the slideshow, these calls can be made by even medical assistants. And they don't even have to be made by nurse practitioners or PAs. Let's see.
Dan, I'm being asked that you just slow the pace a little bit.
Okay, no problem. There are certain core requirements in order to implement the CCM program. These core requirements are that the practitioner has to obtain the consent of the beneficiary. We'll get into that in a little bit more detail later. There has to be written consent. Because there is as we'll talk about later, there is still a copay patient responsible portion. The patient needs to consent to this treatment before they agree to it. The second core requirement is that the provider has to have 5 specified capabilities to perform. And then the third requirement is that the provider has to, directly through as I mentioned before, medical assistant or nurse practitioner, provide at least 20 minutes of non-face-to-face care management services per beneficiary per month. So essentially what's happening is those beneficiaries, those Medicare beneficiaries who sign up for the program, will receive a phone call once a month from the practice. They'll speak on the phone for about 20 minutes. That call will be documented. And during that call, the patient will be asked questions. The patient will provide information about the medications they're taking, about their condition, about how they're feeling, about if they've had any flare-ups of their condition. And all of that information will be taken down and provided to the practice. Let's talk about reimbursement potential. Obviously, CMS realized that they were never going to be able to get medical practices to adopt CCM if the physicians weren't reimbursed for it. And the reimbursement is actually fairly substantial. In 2015, the average amount that a practitioner will receive for chronic care management is between $40 and $50 a month. In New Jersey, I think it's around $45 a month, but I'm not 100% sure. And that, again, is for 20 minutes of staff time. As I mentioned earlier, CCM is not exempt from beneficiary cost-sharing deductibles copays. The copay is typically around $8 a month for a patient who participates in this program, which is a lot less expensive, even when you add it up per year, than an emergency room visit would typically cost, or more extensive care would typically cost. So it does make financial sense for most Medicare beneficiaries. Potential revenue, CMS estimates that practitioners enroll 500 patients, which is what Medicare describes as fairly average throughout the country, can generate an additional $200,000 in revenue. That is fairly substantial. That's per physician. So per physician in a practice, obviously if you have multiple physicians, you multiply that by the number of physicians, you're talking about some significant numbers. Some practices that are busier obviously could generate more than this. This projection is obviously just for the CCM services alone, right? The 20-minute face-to-face visits, but it doesn't include the additional treatment that comes out of these phone calls. Inevitably, when a certain percentage of the people who are called require follow-up care, require an office visit that they otherwise wouldn't receive. Medicare is well aware of this, and Medicare still believes that even though this will result in a greater number of subsequent visits, that overall, in the long run, patients who do this will require less expensive care than patients who are not involved in this program. Some other financial benefits of the CCM program. CCM payments have the potential to increase revenues, as I described before. CCM offers a bridge between fee-for-service and value-based reimbursement. And what I mean by that is, as most of the people on this call probably realize, fee-for-service, while I don't think it's necessarily going to die anytime soon, fee-for-service is certainly an old method and not necessarily the only or certainly not the best method of reimbursing physicians, because it reimburses for the volume of care rather than reimbursing for the quality of care. So CCM is sort of that first little baby step for a practice to get involved in providing care and getting reimbursed on something other than a pure fee-for-service basis, and being held accountable and providing service that's designed to avoid future costs, which is something that both Medicare and private insurance companies are looking to do. It also enables providers to have a new skill set in terms of dealing with population health management, which is something that providers are going to be held accountable for going forward. Again, this is a move away from kind of a traditional model of providing health care. Let's talk about some of the details. Again, I'm not going to get into a crazy amount of detail here, but some of the things are sort of interesting. So I mentioned before that beneficiaries have to have at least 2 chronic conditions. That's a fairly low threshold. First of all, Medicare has not defined what constitutes a chronic condition. The thought by Medicare is, we don't want to hold physicians accountable. You may have a patient that has typical chronic conditions like congestive heart failure, diabetes, other things like that, rheumatoid arthritis, or you may have someone who has just obesity, chronic pain, something like that. It can vary significantly, obviously. And it turns out that most probably more than 50% of Medicare eligible patients have 2 or more chronic conditions. So most of your Medicare patients in your practice are going to meet the criteria of CCM. The conditions have to place an individual at significant risk of death, acute exacerbation, decompensation, or, and this is the most common one, functional decline. So many, many things can result in a functional decline on behalf of a Medicare patient. I talked about chronic conditions. Which providers are eligible to bill? So physicians are eligible to bill CCM, advanced practice registered nurses, physician assistants, clinical nurse specialists, certified nurse midwives are all eligible to bill for CCM. Non-physician practitioners and limited licensed practitioners, such as clinical psychologists, social workers, are not eligible. Only one provider can bill CCM services. So if the primary care provider is billing CCM services, then a specialist provider cannot, and vice versa. For the most part, CCM has been a program that's been adopted by primary care physicians, but not exclusively primary care. I've spoken with a number of CCM companies that actually provide CCM services around the country. They've said that they've implemented CCM for gastroenterology practices, as well as cardiology practices, some rheumatology practices, and other specialty practices that they're regularly dealing with chronic conditions. Let's see. We'll go to the next slide. I'm skipping over some of these slides. So are there any prerequisites to furnishing CCM services? Medicare recommends that before CCM services be provided, that the patient receive either an annual wellness visit or a physical exam. So interestingly, Medicare doesn't require that, but they recommend it. They want the patient to have a face-to-face relationship with the provider before CCM services are implemented. Certain services cannot be billed in the same calendar month as CCM. They include the 4 that I've listed here: transitional care management, home health supervision, hospice care supervision, and certain end-stage renal disease services. Any other services furnished to a beneficiary may be billed during the same month as the chronic care management. So you could have a regular office visit, you could have a physical, and in the same month you're still doing chronic care management. The idea being that Medicare doesn't want to interrupt the flow between the provider and the patient of that monthly non-face-to-face visit. Skip through this. Okay, so let's talk about, I mentioned 3 core requirements earlier in the presentation. The first one is obtaining the beneficiary's consent. There are a number of requirements. Medicare does take this fairly seriously. The beneficiary has to, Medicare, CMS does not provide a consent form. They rely on the provider and counsel to prepare a consent form on their own, but it has to contain all of these elements describing, these are all fairly common sense. You have to let the patient know what CCM is, what they're going to be doing, how it can be accessed, because as we'll get into later, all of this has to be maintained electronically and be accessible to other of the patient's providers. These are a number of things that have to be required, that have to be provided to the patient in order for them to provide informed consent. A copy of the consent form is maintained in the medical record, which is obvious. The patient has to be given an opportunity to revoke their consent, at which point the services are discontinued. The second core requirement we talked about was ensuring that the provider has the 5 specified capabilities needed to perform CCM. These are really important because a provider that doesn't have these core requirements, these 5 specified capabilities, can't bill CCM services and can't perform them in a way that CMS wants them to. Here are the 5 capabilities. You have to use a certified EHR system. That goes without saying. You must have EHR. You have to maintain an electronic care plan, which is often part of the EHR, but not always. You have to ensure beneficiary access to care, which is a general requirement that Medicare uses for a lot of its programs. You have to facilitate transitions of care, meaning transitions of care among and between specialists and facilities such as hospitals, long-term care facilities, and the provider that's billing for the CCM has to also coordinate the patient's care. But that's a very common component of what a primary care practice does, even prior to CCM. I have a lot of information in this slide regarding the use of certified CCM technology. I'm not going to get into the details here, but they are in my PowerPoint if you want to access them later. These are a list of items that are typically included in a care plan. Again, Medicare is leaving a lot of this up to the practitioner and not imposing very strict requirements. These are some of the things that that they recommend. I'll list some of them: problem list, expected outcome and prognosis, measurable treatment goals, symptom management, community social services, coordination of care with other providers, medication management, etc. The important thing to understand is that when CCM is performed by the employee or the agent of the practice, the physician isn't excluded from that process. Information that's gathered from a patient has to be conveyed to a responsible physician who's treating the patient, and the physician has to react to it. Either information that's received doesn't require further action, or information received requires follow-up with the patient. It requires confirmation that certain medications are being prescribed or taken, or certain tests are being prescribed and followed up on. If a physician is not prepared to follow up with the information, then not only should that physician probably not get involved with CCM, but CCM could be a liability for that physician. You can imagine a situation where a patient is on the phone with the CCM provider, tells the provider that they've stopped taking their medication. That information never gets to the physician, and the patient has a bad outcome as a result of that. One can imagine that could result in litigation. Medicare has not spoken to that. There is no immunity that inures to physicians that are involved with CCM. It's the same responsibility as if a patient came to the physician's office. use of certified EHR to create a care plan. Basically, CMS requires the use of some form of electronic technology to develop a care plan. But it does acknowledge that most EHR technology is limited in its ability to support electronic care plan at this time. So CMS is sort of being lenient with the care plan and the electronic care plan, how that interacts with the EHR technology. In terms of who has to have access to the electronic care plan, CMS has 3 basic requirements. And understanding these requirements is critical because if a practice doesn't have the technological ability to meet these requirements, then it will not be able to perform or bill CCM. First requirement is that the care plan has to be accessible on a 24/7 basis to all care team members who are furnishing CCM services. A provider must electronically share care plan information with other providers who are caring for the beneficiary. Again, 2 or more chronic conditions. If those chronic conditions are being handled by specialists, that information has to be provided to those specialists. And the provider must make available a paper or electronic copy of the care plan to the beneficiary. Make available is important because that doesn't necessarily mean that the provider has to send the information, but it has to make it available, presumably on request by the patient. Beneficiary access. The provider furnishing CCM has to provide a means for a beneficiary to access the team. When I mentioned 24/7, what it means is that's accessed by the beneficiary. So an on-call service would be sufficient in most instances to meet that requirement. Ensure that the beneficiary is able to get successive routine appointments. Again, this is a benefit for the practice. Being able to provide appointments to patients, to beneficiaries, is a benefit to the practice and to the patient, but the practice has to be able to make room for it within their busy schedule. And provide enhanced opportunities for communication with the beneficiary through telephone methods, internet methods. Transition of care. A provider has to have the capability to provide transitional care. For patients in the ER, the provider has to be able to follow up with that patient. These are things many practices can do and really should be doing anyway. To provide post-discharge transitional care management, coordinate referrals, share information electronically. We talked about some of this before. CMS wants to see that the provider who's performing CCM basically has the ability to coordinate care and to act as, to quote a relatively old term in healthcare, a gatekeeper for the patient. We've talked about coordination of care. The 3rd core requirement is providing 20+ minutes of non-face-to-face care management services per beneficiary per calendar month. So I've had some of my clients ask me, can we do this every other month? What if we miss a couple months here and there? Do the patients have to sign up every month? They don't want to pay a copay all the time. Taken literally, CMS's requirement is that the care has to be provided every month. This is not designed so that a patient can opt for CCM to be performed less frequently than that. I don't think CMS has been really clear about this, but that's my interpretation of the way the law is written right now. There are a variety of types of services that constitute non-face-to-face care management services. Some important ones: medication reconciliation and overseeing the beneficiary's self-management of medications, ensuring receipt of all recommended preventive services and monitoring the beneficiary's physical, mental, and social condition. Go to the next slide. As I mentioned before, these non-face-to-face services can be performed by a variety of non-physicians, all the way to medical assistants, which makes it much more cost-efficient to provide the service. In terms of what supervision is required, of the staff that are making these calls. Medicare, the final rule only requires general supervision. Some of the earlier iterations of the rule required direct supervision, which would have required that all the services be performed in the physician's actual office, and that the physician be physically present when the calls are being made. But the final rule recognized that that's not practical, and actually it's a I think an excellent change that was made, because now you could actually have an off-site call center. You don't have to have physicians on staff. You could have these calls made from a provider's home, theoretically, as long as the physician on a fairly regular basis, let's say once a month, goes through the information and makes sure that proper information is being obtained from the patients during these calls. The 20-minute minimum requirement, a couple points about this. Time spent providing services on different days can be aggregated, so you don't have to necessarily, theoretically you can call a patient twice a month for 10 minutes each and you'd meet the requirement. If 2 staff members are furnishing services at the same time, only the time spent by one individual may be counted, again, if it's at the same time. So you can't have 2 staff members on the phone, not that it would make sense to do this, but CMS has thought about this because I guess people try to get away with things. You can't have 2 people on the phone and talking for 10 minutes, multiply it by 2 and get to the 20 minutes. Time of less than 20 minutes during a calendar month cannot be rounded up to meet the requirement, and time cannot be carried over from a prior month. So if you spend 30 minutes one month, you can carry the extra 10 over to the subsequent month. Remote monitoring. Practitioners who engage in, this is a direct quote from CMS, practitioners who engage in remote monitoring of patients' physiological data may count the time they spend reviewing the data towards the monthly minimum. This is important, but you can't include the time that the beneficiary spends under monitoring or wearing a monitoring device. So if the provider spends 5 minutes reviewing or 10 minutes reviewing the results of the device, the monitoring device, those 5 or 10 minutes can be used toward the 20-minute requirement. At this stage, I have a slide that talks about some of the things that you're going to need, whether it's done by a law firm or done by another third-party entity. You're going to need someone to come in and perform a gap analysis of your current requirements and determine whether or not they're missing components in order for you to meet the CCM requirements. You're going to need to develop some sort of a business plan within a practice and return on investment analysis. There are expenses. The main expense associated with CCM is the cost of the individual who's going to be making the calls and the technological costs. The technology costs tend to be one-time costs. They don't necessarily have to be ongoing, but they can be significant upfront. Your staff is going to need to be adequately trained. Anyone making these calls has to be very carefully trained and monitored to make sure that they're asking the right questions and they're gathering the right information. Some other thing, I'm not going to go through every one of these. You need to have supportive technology that meets all of the CMS requirements. You're going to have to incorporate this within your coding and billing processes, and obviously incorporate this within your HIPAA and other privacy law compliance plans. That being said, I will now, if I can, bring up the questions. I'm done with my actual form.
I can read them if you'd like.
Yeah, why don't you do that?
Okay, the first question is, does this include managed Medicare Part C as well as Part B?
Medicare Advantage plans it's interesting, I have a slide on that, I probably should have gone over it. Medicare Advantage plans technically should provide reimbursement for CCM services, although the people I've spoken to and what I've read, it's hard to say that it's been formalized that they're required to reimburse it, but technically they should reimburse it, and if it's something that a practice is interested in doing, then they should communicate with their with the carrier And if there's an issue with it, I'd be happy to talk to them about it. I mean, it definitely should be part of that.
Any other questions, folks? Okay, here comes another one. Can LPNs do the initial care plan, or does it have to be provider-physician?
Well, if in your practice a care plan is typically performed by an LPN, I don't know anything about, because that's really a question that's outside of CCM, because you have therapists for patients even if you don't implement CCM. I'm not 100% certain whether or not I don't know of any requirement that says that a physician or that an MD has to put together the care plan. And assuming that your practice utilizes care plans through non-physicians now, there's no reason that it couldn't continue to do that through the CCM model.
Okay, can you please elaborate on the electronic care plan, and can this be a written care plan scanned into the EHR?
Yeah, you don't have to have a, interestingly, the electronic care plan, according to CMS, really only just has to be available electronically. In other words, I mean, theoretically, it could be a PDF that's been scanned in and put into the patient's chart. It just has to be available electronically. I mean, obviously, there are more sophisticated ways of doing it than simply scanning a paper document, and you could input the information through a more sophisticated program that allows the information to be integrated through different data fields with your EMR system. But there's nothing in the regulations that require that you do that, and a PDF scanned in is probably fine.
Okay, are physical therapists and/or chiropractors able to perform CCM services under guidance of a pain management doctor?
That's a great question. I mean, CMS did not speak to the concept of having physical therapists or chiropractors be involved in the care. I have to look into that further. They specifically mentioned advanced practitioners, PAs, and medical assistants. I mean, I think one can make a very good argument that if a medical assistant can do it, then certainly a chiropractor can do it, because a chiropractor is an independent practitioner. But Medicare does not elaborate on that. So it would require probably a phone call to CMS to find out what their position is on it. And it's also state law driven. The other thing that I forgot to mention is, what CMS basically says is you can have anyone make these calls as long as it's in compliance with state law. So in some states you may be able to just train a layperson to make these phone calls. In other states you have to have someone who, in other states a medical assistant wouldn't be appropriate because state law requires some higher level licensing.
Okay, I think you just answered the next question, so I'm going to go on to the following. Does the care plan change every month with every non-face-to-face encounter?
Not necessarily. The care plan, if the patient's condition doesn't dramatically change, if the patient doesn't have an additional chronic condition, then the care plan would not change. It might remain the same for a year or even more. But I would say that most likely the care plan is going to change at least once a year, and certainly not every time that the patient is called on the phone.
Okay, is the time spent reviewing a chart before calling patients included in the 20 minutes? And if the patient is called and there is no answer, is the time spent calling the patients part of the 20 minutes?
No and no. Good question, because you could spend a lot of time calling patients. But the answer is definitely no. Reviewing charts is not. It has to be. There are only very few exceptions to the actual call with the patient applying to the 20 minutes. And I mentioned them in my presentation. One of them is reviewing this any remote monitoring, but no, reviewing the patient's chart definitely does not apply. And if you call and get a busy signal or call and leave a message, that doesn't apply either.
Okay. I don't think we have any more questions. Is there any more questions? Are medical assistants licensed in New Jersey? And does CCM fall within their scope of practice? I think you answered this, but let's get that in again.
Yeah, I believe New Jersey does have a licensure process for medical assistants. And my interpretation at this point in New Jersey, and New Jersey hasn't spoken much because this is a very new program, is that medical assistants can perform these services.
Okay. Are you able to provide an example of a consent form?
Not during this webinar, but...
Right. Well, I will be sending the presentation out to all attendees. So if you have one that you would like me to forward to attendees, let me know.
Okay.
And I can get that out to them.
Okay. We'll talk about that.
Okay. Any other questions? As I mentioned, a couple people are asking about the presentation. The presentation is going to be emailed to all attendees of the webinar. Any other questions? I think that's it, Dan.
All right, everyone. Thank you for your...
Thank you very much.
Take care. Take care.
Thank you, everyone.